Hello everyone, my name is Keshav Patel. I am a fourth year medical student at Western Michigan University, Homer Stryker MD School of Medicine, and I am extremely excited for this virtual poster presentation. Our poster title is While We Wait, Malignant Cardiac Tamponade in a Patient with a Previously Stable Pulmonary Nodule. For this project, I worked with Dr. Simran Kent, who is an internal medicine resident, and Dr. Prashant Patel, who is our fourth year internal medicine clerkship director. So let's start with the introduction. First of all, a pulmonary nodule is a less than 30 millimeter mass that is surrounded by pulmonary parenchyma. Initial evaluation of a pulmonary nodule should determine the likelihood of malignancy using both clinical and imaging features. Likelihood of malignancy can be low, less than 5%, intermediate, between 5 to 65%, or high, greater than 65%. Low-dose CT scans can detect incidental pulmonary nodules and are crucial for lung cancer screening in tobacco users. Although the risk of overdiagnosis exists with screening, we present a case demonstrating the importance of active surveillance in a high-risk pulmonary nodule to prevent rare and advanced complications such as malignant cardiac tamponade. So let's dive right into the case. A 59-year-old male with a past medical history of heavy tobacco use of 1.5 packs per day for 30 years and a solitary left upper lobe pulmonary nodule presented with a subacute cough, dyspnea on minimal exertion, and pleuritic chest pain. His single pulmonary nodule was diagnosed 18 months prior to admission and was approximately 16 millimeters with spiculations. He had not undergone biopsy due to personal preference. The exam revealed tachycardia at a rate of 112 beats per minute and diminished breath sounds bilaterally, but was otherwise unremarkable. So let's take a look at Figure 1, the initial chest x-ray. In this chest x-ray, there is moderate cardiomegaly. A CT of the chest was performed and revealed a large pericardial effusion with a persistent spiculated pulmonary nodule in the left upper lobe. In figures 2A and 2B, we can clearly see the solitary pulmonary nodule. In figure 2C, we can clearly see the pericardial effusion. Echocardiography then revealed tamponade physiology. Thus, the patient underwent urgent pericardiocentesis and surgical creation of a pericardial window. Looking at figures 3A, 3B, 4A, and 4B, we can clearly see that the pericardial effusion was improved after pericardiocentesis. Cytology of the fluid confirmed metastatic adenocarcinoma consistent with a lung primary. Moving on to the discussion. Malignant pericardial effusion with cardiac tamponade is a rare complication of non-small cell lung cancer. Although symptoms of a pericardial effusion may be the first sign of occult malignancy, this case highlights the importance of aggressive surveillance or tissue biopsy in high-risk pulmonary nodules. Per Lee et al., these discussions may allow earlier initiation of treatment to reduce the risk of oncologic emergencies like malignant cardiac tamponade, which carry a poor prognosis. Our patient presented with the rare complication of a malignant pericardial effusion with cardiac tamponade from non-small cell lung cancer. In conclusion, the main takeaways of this poster presentation are that initial evaluation of pulmonary nodules should determine likelihood of malignancy using clinical and imaging features. If there is a low probability of malignancy, then perform serial CT scans. If there is an intermediate or high probability of malignancy, then perform aggressive surveillance with FDG, PET, or CT, and obtain a tissue biopsy. The key point and main takeaway from this poster presentation is that aggressive surveillance or tissue biopsy in high-risk pulmonary nodules may allow for earlier initiation of treatment to reduce the risk of oncologic emergencies. Thank you for your time, and please let me know if you have any questions. Thank you.